Welcome again to Edu-PIC. This is Ahmed Sharif, and we are still continuing with our series about renal replacement therapy in PICU, and today we talk about CRRT or continuous renal replacement therapy. As we said before, there are multiple types and modalities to deliver dialysis or renal replacement therapy. Last time we have talked about peritoneal dialysis, and this time we talk about CRRT, including CVVH, CVVHDF. So we're trying to cover principles and theory behind CRRT or CVVH and know the machine and how it works, and talk a bit about how to prescribe and manage your dialysis plan. So let's start with the principles. So just to start, CRRT in pediatrics has been mainly introduced in the 1980s as a PICU modality, or like a dialysis modality in acute care. It's been slowly growing into practice, but basically it's been slowly growing because of a lot of technical challenges, including the filter surface area, the circuit tubing size, which both would compromise a lot of the circulating volume of a child, the vascular access and how to get it, and how to get it to be sufficient to circulate the blood, pricing and finances to deliver this equipment when they're modified for peds, and training staff. As you can see here, going from the left all the way to the right. So in the 1980 was the specific 1980 was this first application of continuous arteriovenous hemodialysis. Then 1985 it was combined with ECMO to facilitate ultrafiltration. Then starting from the 2000, although 2005, we started having pediatric circuits. So if you're talking about real activity with CVVH, it's just really recent. To 2010, we started having machinery that are more child-friendly. And then we started having, in 2015 forward, off-label use of machines for ultrafiltration and other suggested new modalities, like something we call NIDUS, which is mainly introduced for little infants, and that was developed in Newcastle. And then in 2020, we are becoming more confident of using different machineries and different circuits to deliver different modalities of CRRT. So why do we need it? I mean, it's fairly new. We've talked about PD, and PD seems to be a very good option. Well, there are contraindications to PD, so sometimes you can't deliver PD because of peritonitis, because of abdominal sepsis, because of defect in peritoneal cavity, necrotizing enterocolitis or gut perforation, or different other relative stuff like having a VP shunt that you think is infected. You can also need continuous renal replacement therapy to be delivered in a veno-venous way to tackle non-renal indication of dialysis like hyperammonemia, which is not efficiently cleared through PD. Or you can just be targeting the management of your fluid and the removal of the solutes and the fluids in a more restricted and controlled way in comparison to the little bit unpredictable PD method. So how does it work? Well, the whole point is to access one of the big vessels with a big catheter, in this context called VASCATH, that should have at least two hubs. One of the hubs is going to be used to pump the blood out of the patient through cycling points that don't really touch the blood, and that blood would be cycled into a filter and then out of the filter back to the patient through the other hub. There are different access points to deliver fluid, either pre-filter or post-filter, and other points to deliver a dialysate and to get the effluent or the dialyzed fluid out. The principles that we still use are the same, like the same principles that we talked about since the first lecture, which was all about AKI and renal replacement. So we're basically using the principles of conviction and diffusion. If you don't use a dialysate through this hub, then basically you're only relying on conviction, where there's going to be a drag of fluid shifts, dragging some solutes with it, and that will be all taken out as an ultrafiltrate. So the ultrafiltrate is mainly the fluid, as we know, but the dragged solutes come as a consequence, which is called convection. Obviously, that depends on the pressure gradient and how long are you keeping the fluid in the filter, so how quick the fluid is running, and a lot of other factors, including what's in the fluid. While if you add dialysate with certain amounts of solutes, then basically you're relying on diffusion from the higher concentration points to the lower concentration points. And basically these are the same principles that we've been talking about all over our last two talks. So just let's go through some nomenclature. So if you only rely on convection and you're not using any dialysate, that's called CVVH. If you're only relying on the dialysate with not much of relying on any extra fluid, which makes you more reliant on diffusion, then it's called CVVHD. So in that case, you're here ultrafiltrating with some solute shifts, while here you're mainly trying to drag solutes more than you're trying to get fluids. If you are targeting both, then that's called CVVHDF, which basically continuous veno-venous hemodialysis and filtration. That again explains it a bit more. So as you can see, access point, blood is going out, there is pre-fluid, there is effluent coming out, and point for post replacement fluid, and the blood goes back. That's called CVVH. If you've got access and you're putting dialysate in, no extra fluids, and you're only getting the effluent and the dialysate out, that's called CVVHD. And here again, access point, you're giving fluid and you're also giving dialysate, and you're getting the effluent and the dialysate out. That's going to be called CVVHDF. Now let's talk about vascular access, because it's one of the cornerstones of CRRT. If you don't have a good enough vascular access, you're not going to connect the patient to a machine to begin with. So this is a picture of the vas cath. Obviously there are different kinds of catheters and there are different manufacturers, but it's one of the famous ones. Basically what we're aiming for is to have an axis that has got the least possible resistance, and to achieve the least possible resistance, as we know from physics, you need the biggest diameter, because the main influence on resistance comes from diameter, because it's inversely related to resistance up to the power of 4. So a small change in diameter changes resistance massively. So to achieve that in a little child, you need to go with bigger catheters than your usual central lines. So in a neonate, you can go with 7 French. As you can see with the whole table here, you can go all the way to 10 or 12 French as you go bigger to adult size. But if you can compare these sizes to what you do with your usual central lines, these are massive. Okay, so we talked about radius, and now we're giving you some suggestions about how far you should go with your catheter, because obviously as the child size changes, the suggested length of the catheter would change, and how far you would go with your catheter would change. Obviously, if you're accessing the internal jugular, it would be different than accessing the femoral vein. Each one would need a different length to get the proper site of the catheter. But also remember that length is part of the equation, and that would affect your resistance. So these lengths here are suggested, but you need to confirm with a chest x-ray or an echo if your catheter is in the right place, and accordingly adjust or pull back or re-site. And that would be our suggestion for you from that point of view. So, still with vascular access, where do we go? Well, in adults, there are recommendations that would say your first choice should be the right internal jugular, and then if that's not accessible or there's a problem with it, then you go with your second choice being the femoral. Left internal jugular would be your third choice, and subclavian would be your fourth. That can be applicable to our cohort of teenagers as well. And the whole point is, again, getting the least resistance, because you want the blood flow to go as direct as possible to the heart without lots of turbulence. So it's no-brainer that the right IGV is the best. Then the femoral can also still be as straightforward as possible, while with the left internal jugular in adults, the stretch from the left internal jugular all the way to the SVC on the right can have different points of turbulence. Again, subclavian looks like it's not a straightforward choice for a big catheter. Then what do we do with kids then? Well, in peds, it's different than teenagers. So our first choice is going to be the internal jugular, whether it's right or left, because the extension on the left side in pediatrics or in little babies is not as problematic as it is for adults. And your second choice would be your femoral vein, and your third choice can be the subclavian, but to be honest, it's suboptimal. Why is it suboptimal? Because if you're getting a smaller catheter in the subclavian in an adult, imagine how that can be for a little baby. It's quite difficult and it's quite different. Let's talk about the machine and the circuit. Well, as you can see, there are different types of dialysis machines that have been developed over the years, and each unit can have whatever, and in that context you need to know which machines do you have, or if you are gonna get machines, you need to know what's the difference that each one of them is gonna offer you, and how applicable is it for you to use one of them over the other, from pricing, from types of circuits, and from compatibility to different age groups. All right, let's take this one as an example just to explain how the circuit goes. So the blood goes from the patient through the circuit to the filter, as you can see here. All right, then it goes out of the filter from the top all the way back to the patient. You can see that basically these wheels are used as pumps, but they press on the plastic of the circuit to pump the blood, so they don't really touch the blood. Then you've got an anticoagulant connected through here to an entry point that would be usually around here. So anticoagulation goes to the circuit from one point, and there's a point for the pre-filter dilution below that. So anticoagulation goes around here, pre-filter dilution goes around here before they get to the filter. Then you've got a point for the dialysate, as we explained earlier, and it goes straight into the filter, and another point to get the effluent and the ultrafiltrate out. What we need also to realize that when the blood goes out to this point before it goes back to the patient, there is a point for post-filter dilution or post-filter fluid insertion from that point downwards. Okay, so we know about the circuit. How do prime it? What do we mean prime it? Prime it basically means getting the circuit all filled so that there's a continuity with the patient's blood, because you can't keep the filter being all filled with air. So the standard is using saline. So we fill the whole filter with saline before we connect it to the patient. And that's the common default approach. But it's not to every kind of patient or any size of patient, because if the child is little, which is most of the cohort that we deal with in PICUs, if the child is below 10 kilograms, then the best method is to prime it with blood. Because if you use that whole circuit, if you fill that whole circuit with saline, then you're going to dilute the patient's blood significantly. Let's take an example. Let's say we've got a 5 kilogram baby. The blood volume for that baby would be about 400 mils, because it's 80 times 5 is 400 mils. Usually the smallest circuit volume is 100 mils, so that would be about 25% of the blood volume. If that's all saline, then you're getting the patient significantly into anemia, and that's going to affect the patient significantly. So we usually prime any circuit for a child less than 10 kilograms with blood. There have been some sources mentioning albumin, but to be honest, it's not commonly used, and there is no evidence base to support it as a colloid in hemodynamic instability. If you're using colloids, you might as well use blood. And there is the fact that you can prime the circuit with the patient's own blood or the patient's own circulation. That is only applicable in big children who are fluidly overloaded to the point that you want to get some fluid off them. And again, it's not commonly used in pediatric practice. One thing to mention, if you're using blood, just be careful, because blood is of about 25% of the blood volume can cause a lot of problems like cytokine release, which might cause the patient to go down being hypokinetic. You need to be ready with calcium, you need to be ready with bicarb, and you need to be ready with adrenaline just in case. Okay, so we've learned about the circuit and how to prime it. It's about time that we get to understand what we're doing with our dialysis plan and how to prescribe and manage the dialysis. Well, let's start with titrating the blood flow. Usually start with titrating the blood flow around 5 ml per kilogram per minute. That can be titrated anywhere from 3 to 10 ml per kilogram per minute, but it depends on a lot of factors. But the biggest factor is how big is your vascular access and how strong is the resistance. Then you've got fluids and dialysis that you need to titrate. Well, you need to know what kind of effect do you get with the spectrum of rates that you get. So the higher the rates, the higher the clearance of solutes. The lower the rates, the more gentle you are with your electrolyte balance and your protein loss. We usually start around 2000 ml per hour per 1.73 millimeter square of body surface area, or for simplicity 20 ml per kilogram per hour. Then you can try to titrate up and down. Fluid removal is another thing that we're trying to achieve and trying to control, basically, or you can call it fluid balance. Again, that depends on your dialysis plan and the patient's fluid status and the pressure gradients and what you need, what you're aiming to achieve. If you're aiming negative, always start gentle, so around 1 to 2 ml per kilogram per hour, just to see how the patient's going to tolerate that, and then you can escalate accordingly or just be still and stay at that point. You can always control fluid balance as well if you feel the patient is not taking it, by adding fluid back, or if you really need to get fluid off and the patient is a bit hypotensive, then you can use some vasopressors like NORAD or vasopressin. Well, some principles to know again about what we're doing with filter fluid. Apparently, as we said, there are 2 points to add filter fluid. So initially, just to know that there are effects that you get from filter fluids. So bicarb ions are freely filtered, and that means that you need always to replace them. So it's always wise to use bicarbonate based solutions to add to the circuit, and that would help with your pH. Using the pre-filter dilution point can cause low incidence filter clotting, because basically you've got more fluid and more fluidity getting into the filter itself, but it's less effective from the solute clearance point of view. While if you add the filter afterwards, then there is higher incidence of filter clotting, but also higher efficacy in solute clearance. Then we talked about the fact that you're always adding anticoagulation, and that's important because the whole blood is running into a circuit that is not part of your usual circulation. So there are 2 methods to deliver anticoagulation. Historically, up to this point, people have been always using systemic, which is mainly heparin, but most recently new methods using regional anticoagulation, mainly using citrate, has been developed and became more preferred. So if you're using heparin or systemic anticoagulation, that's the most common, most studied, people are mostly trained in it. It comes cheap, so in a developing setting or a unit that needs to be more rationalizing about the spending, it's sensible. It's easily monitored because you can monitor your coagulation levels easily with the standard methods. There is risk of hemorrhage, as you know, which is the downside of it. Risk of heparin resistance, again, that happens with time with any patient on heparin infusion, and risk of having HIT or heparin-induced thrombocytopenia. While the regional anticoagulation using citrate is becoming more preferred because it avoids systemic anticoagulation, so it doesn't affect the patient generally, which means less need for blood products and less need to be worried about bleeding. It gives the filter higher lifespan, so the filter is less likely to be clotted. But the downside is it causes metabolic and electrolyte imbalances, and it's a bit expensive. How do we monitor? Well, for the heparin, obviously, you can use either the ACT time being around 180 to 240, or you can use the APTT time around 40 to 60. You can also use the anti-10A that can be targeted around 0.4 to 0.5. While the regional citrate anticoagulation should be monitored through 2 points. So the circuit itself can be monitored pre-patient by keeping the ionized calcium around 0.3 to 0.4, while the patient ionized calcium through the patient himself needs to be around 1.1 to 1.4. To understand more, this is how it goes with regional anticoagulation. So the blood is going out. Step 1, you infuse your anticoagulation, which in this case is citrate-based fluid. That chelates the calcium, and the ionized calcium gets consumed all the way down to about 0.4, which is basically how the anticoagulation happens, and your bleeding time goes up. And the blood goes to the filter. Your dialysate should be calcium-free, which means all of the chelated calcium citrate combination would be coming out with the effluent. Then the blood goes out of the filter. On its way back to the patient, you have got your post-filter hub where you can monitor your calcium level, and that is where you should keep it around 0.3 to 0.4. And as the blood goes back to the patient, it combines with the venous blood, which basically normalizes the ionized calcium by mixing the low levels with the higher levels in the patient, so you get an average of a normalized level, which prevents systemic anticoagulation. Then whatever has been left over of the citrate gets metabolized by the liver, which basically releases bicarb, and the calcium gets released as well, which adds to the normalizing of the calcium level. But you still need to monitor the calcium through the patient himself, and if the calcium is low, you need to supply it through a separate central line away from the filter, so you don't add the calcium directly to the filter. And that's basically how it's been done. All right, thank you very much. So just remember that CRRT is of big impact, and it actually can help with your unit's outcome with critically ill patients. But it needs a lot of training to the whole team, so doctors and nurses, and mostly nurses because they're going to be running the machine. If you've got CRRT in your unit, then get familiar with your machine and your available fluids and your circuits and your anticoagulation protocols, and try to review the prescription for different patients and see how that goes with you. Thank you very much, and thank you for following the whole series